unemployment, the issue of stress and anxiety, and particularly now in terms of, I don't know if you pay attention to the ongoing state politics, but medical marijuana may well be on the ballot as far as therapy. And it's been advocated, and there's a lot of literature now saying that it's a stress-reducing agent and stress-reducing and reduces symptoms in inflammatory bowel disease. And there's a lot of literature right now that says that it does reduce symptoms. Most of it comes out of Israel. That same group that showed that pot reduces symptoms, when they went on to look at inflammation, it does nothing to inflammation in inflammatory bowel disease. It does not change it at all. So the disease will progress. You'll feel good during the process, but the disease will progress in terms of stricturing and blockage or other things. But you won't have any cramping, or you won't care about it. And so the notion is in this circumstance, it's a good example where you can feel better, but the disease can still progress. And so that highlights that how our goals are changing now, and just feeling good is not good enough in terms of being able to address the issues on inflammatory bowel disease.
Actually, if I can add just a little bit, and I really don't want to get into a discussion of medical marijuana because it can get really heavy and hot. However, in agreement with you, it can also mask a lot of things that are going on, also mentally. And with mental health and mental illness, it can mask a depression. It can mask some anxiety. And yeah, it makes you feel good for a little while and here and there. But I can't even give a diagnosis to a person who is telling me that they've been using marijuana for long periods of time. You've got to be totally away from it in order for me to actually understand and diagnose you with a mental health illness or just stress and anxiety are two different things. Stress is not a mental illness. There are different things that stress is part of, but anxiety is a mental illness. It's a mental disorder, and there's a lot of differentiation in that. And yeah, those types that can actually mask some situations.
Young lady in the back, she has a question.
Okay, random question since I have you all here. Have you had any Crohn's disease patients that have breathing problems or hot flashes? Have you seen that, or is it really
Having what kind of problems, honey?
like breathing problems?
Breathing
or
problems?
Like hot flashes also.
Related to a medication or just on
Just
Related to
Crohn's.
Crohn.
just Crohn's?
She has to go to a lung specialist now because she's having a hard time breathing. She's not getting enough oxygen.
And then I get hot flashes
They're
also.
doing chest x-rays, they're doing
Or no?
Maybe she has GERD too.
Yeah, and
Well,
a lot of times you can have.
she does have rheumatoid arthritis and fibro. So, but they're looking more into the lungs to see if it's a bacterial or if it's a,
Well, there's a lot of overlap too, or there is some overlap between a lot of the autoimmune diseases. So you can have, for example, rheumatoid arthritis and inflammatory bowel disease, and there are certain conditions like with rheumatoid arthritis that could affect the lungs. So that's an issue. A lot of times when you have active inflammatory bowel disease, you can have night sweats and fevers and feeling, just feeling really hot and not necessarily even having the fever. So I don't know if that necessarily correlates with this kind of symptoms you're having, but I mean, when you're having a flare with any kind of inflammatory disease, you can have fevers and feel unwell and there's really, I'm trying to think if there's any overlap between any kind of lung conditions and Crohn's disease or ulcerative colitis.
Well, you can have some extraintestinal manifestations of inflammatory bowel disease, and sometimes you can get some mnemonic involvement, but usually there's something objective that you'll see, either an infiltrate on the chest x-ray or some kind of objective finding on a breathing test, and that's why it's worthwhile to get a pulmonologist involved to really clarify whether there's some additional objective findings that might underlie that. So it's just
And two, if you're on any kind of anti-TNF, any of the injectable medications, any things that really suppress the immune system, also increases your risk for certain infections in the lungs. So if you grew up someplace where you were exposed to aspergillus or histoplasmosis, sometimes those infections can affect the lungs too and make you have trouble breathing if you're on medicines like Remicade or Humira and stuff. And that's one of the risks of those medications, is that it can prevents your white blood cells from attacking your valve, but may also prevent your white blood cells from fighting off,
But wouldn't
other
that usually
infections.
happen like when you first begin the medication? Cause
Not
I've had
necessarily.
Remicade for
Yeah.
8 years.
Not necessarily.
And just to sort of add a comment to that is that if you do get an infection in the context of taking a biologic, usually, and you get a cough, you'll have a cough, it will go on and on. There'll be some symptoms that will go along with it, and it's just there'll be something else. So that's why if you do get a new symptom while you're on a biologic, like a chronic cough, you gotta let someone know about it. You just can't assume that, hey, it's nothing, it's just the flu or something like that. So it's important that there's a new symptom, that you share it with your doctor there, so. Yes, sir.
You've talked a lot about medication. When does surgery become necessary?
Well, the surgery has very specific roles in the context of an ulcerative colitis. If you have such severe inflammation of your colon that you cannot control it with symptoms, with medications, or the medications become so onerous that like repeated uses of steroids and side effects related to it, then there's a role for removing the colon to cure your colitis. And Crohn's disease, if there's an intestinal blockage, there's an obvious role of doing surgery. If there's a fistula, there's an obvious role. If there's an abscess, a collection of infected fluid, yeah, it needs to be drained. And so the surgery has a very, very specific role in those circumstances. So, we didn't want to, we didn't emphasize surgical intervention, not to say it doesn't have a role, it's just that we were emphasizing more the medical side of therapy.
And the current medication, especially the biologic agents, really have decreased our need to send patients to surgery. So people with ulcerative colitis who maybe 20, 25 years ago, we couldn't keep them under control, they were having more and more trouble, they needed to be on chronic steroids, so those are the people we would send for a proctocolectomy, whereas now, most of those patients can be controlled with, their disease can be put in remission with a biologic agent, with one of the injectable medications, and so they can save their colon. And there's benefits to keeping all your original body parts intact and not having them removed for no good reason, so.
Well, if there's no more questions, I think we'll sort of wrap it up here. And I want to thank Jamie for providing this forum for us. And,
Yeah, this is fair.
We're on a strict schedule. We have the room by 2:30.
we certainly appreciate the support, and we'll hope to do this on an ongoing basis. But we have videoed this, and we'll make it available on our website as well as the CCFA website. So if you can tell your friends and relatives about it, so it can act as a resource in the coming year. Anyway, thanks again.
Thanks for coming out.
Thank you all for presenting. You did a phenomenal job.
Hey, we finished on time.